Welcome to Prescription for Primary Care. Today we're joined by Stephane Robichaud, CEO of the New Brunswick Health Council. For several years, he has been leading efforts to measure and report on the province's healthcare system performance. Stephane, thank you for joining us.
Thank you for the opportunity.
So let's just get right into it. The recent data from your 2023 primary care survey shows that there's been a significant drop from 93% in 2017 to 79% in 2023 in residents with permanent primary care providers. So what insights can you share on this?
Well, on first hand, we did have an unusual period of time here in New Brunswick where we've seen a huge increase in immigration to New Brunswick, migration to New Brunswick. So that's a lot of new people that we were not used to getting in previous years. It remains to be seen if it's going to be a trend over time. But that was a significant amount of new people. So that would have had an impact for sure. And we are in a situation that's been expected for some time with the aging of our workforce. So we're seeing, not necessarily in a particular order, but a number of family physicians are reaching that stage where they're retiring. So and there's competition among many jurisdictions around recruitment. So all things being equal, we were getting in a period where it's going to be a challenge to compete with other jurisdictions on recruitment. And we're seeing efforts internally here to increase medical training within the province.
So your health system indicators show that about 52% of the visits to the emergency departments are for levels 4 and 5 cases, which I understand are less urgent conditions that could be treated in a doctor's office. So have you seen this, and what have you seen about the over reliance on the emergency departments?
Yes, it's something we've actually looked into over the years. And what's interesting there is publicly, people often associate the high volume of people in the ER to the percentage of people who don't have a primary care provider. And in fact, what we've seen is a very important component of people going to the ER is that they do have a primary care provider, but they cannot see them in a timely fashion. So general rule is what we're seeing is if they can see their provider within 5 days, they will wait. But we're in a situation where you have a minority of primary care setting that can usually accommodate fairly quickly, next day, same day, next day, appointments, a small minority. And then you kind of jump to the other reality that goes all the way to 5 to 7 weeks wait. And so when people see that, they will tend to go to the emergency room. And another use is after hours clinics. But the thing with after hours clinics is if you think you may need an X-ray or a follow-up of some type, the clinics are really a sort of a one-shot deal. So right. This is really putting pressure on emergency room visits.
5 to 6 weeks just to get that initial consultation with your family doctor, which you should have. And who knows, something as simple as like a sniffle can blow into a bronchitis. And then there you go, hospital pressures. And it's so unfortunate that the access is so elusive.
And another element too, if you look at this from a client perspective, from a patient perspective, we've also learned with time that there's a small percentage of our health service users that are actually big consumers of resources because they have a number of complications and so forth. And we also know that among this population, about 1 in 2 say that they're confident in their ability to manage their conditions, 1 in 2. And many professionals will say to me that they think the actual number of people that are confident is probably lower because people may think they know how to manage it, but that's another thing altogether. Mm-hmm. Where I'm getting to it with this is when primary care is not organized in such a way that it can adapt its services to the needs of these types of clients. So for example, for a number of these people, it's help understanding their chronic conditions or their medications, which doesn't have to be done by a doctor, and is a good example of a clientele that is well served when served in a very true team fashion. These individuals, when they do end up going to ER, they're not getting that continuity of care either. And that's also an issue, and it's very hard to measure the impact of that globally. But it does mean that we're failing for a growing proportion of our population. But because we're also seeing that people with 3 or more chronic condition proportionately are growing with years.
So you recently released the population health survey to residents of New Brunswick. Can you tell us about the focus of the survey and what you're hoping to learn from it?
So it's a survey we've been doing since 2010. And this survey in particular is sort of a unique opportunity in New Brunswick to get the measure of whether it's health behaviors or some socioeconomic elements and experience with primary care is included in that type of survey. When we do this particular survey, we have a fairly high target of respondents that we're aiming for, because what we've done in New Brunswick, for those less familiar, New Brunswick is divided in what we call 7 health zones. And these health zones are fairly big territories. Like Zone 1 is pretty much southeast New Brunswick. We've subdivided each of these zones in communities. And this survey represents the main source of measurements in what we then produce publicly and return back to these communities that enable them to appreciate, first of all, their own individual numbers, yes, but it's also very valuable for them to compare, to see how they may compare to the provincial average and so forth. And what we've seen over time is this information is used from a health service planning perspective to support community needs assessments. But it's also greatly used, and this has been encouraging by a lot of nonprofit local organizations that otherwise would not have access to this type of info, and are using the info often. And for example, a United Way has made it a requirement since about 2014 that these types of numbers be used to justify why a given request for funding is a priority in their area. And similarly, as funding is given and years go by and these measures are monitored, these types of results can give them a sense on whether they're having an impact or not locally. So for us, and I'll also share, being the main source of information, because measurements are sometimes hard to come by, this survey has also enabled us to appreciate just how much variability there can be within a province the size of New Brunswick, depending on what you measure. So before having this type of data, people would say, oh, rural is better or worse, or urban is better or worse. Francophones are faring worse. Francophones are faring better. But this data has really taught us that there is no generalization, really. It really depends on what you're looking at, which geographic area. And each geographic area can be faring fairly well compared to provincial average on one thing and very poorly on another.
Mm-hmm. Okay, so you're really hone in on those numbers, and then nonprofits and other companies, I guess, can also use that number and try to help with healthcare policy development. So you just sent this out? Is it like I heard it was like a postcard, or are you doing it digitally as well?
So the story around that is, for the first few iterations of this survey, how it was done in the past was it was all phone based, and companies could use phone numbers in their databases to locate individuals throughout the province. So I just mentioned there are targets for the 33 communities. And the phone number, traditionally a phone number, you could identify what community the phone number was in by those numbers. And in previous years, that worked fairly well. But with the advent of much fewer landlines now and far more cell phones, it's made that process far more complicated. And also, people have become very wary of receiving calls. There's so much fraud now by phone. It's making that approach more difficult. So this time around, we took a slightly different approach. Every household has received or it will be receiving a postcard with a QR code, with a website address, and there's also a phone number should they require any assistance or prefer to do it by phone. They can register. So we're trying a different approach this time around. But still, the target is fairly high. We're trying to reach about 17,500 respondents overall.
I appreciate the postcards because, quite frankly, you don't get good mail anymore. No one likes phone calls anymore. Even texting, when you get a text, fill out
If
the
it's not personal, if it's not from someone you know, you tend to
yeah.
disregard.
So like
well, we're hoping it's going to work. We've been, I have to say though, when I compare our journey here in New Brunswick and this type of work with other similar organizations across the country, we've been very privileged with the support that we've received from New Brunswickers. Our response rates are quite higher than other jurisdictions. So we've been very fortunate that way. It's just that there are some of these hurdles that are coming up along the way that we can explain because technology evolves and people's habits are evolving. But in general, we're very lucky to be benefit from the support of New Brunswickers.
Amazing. So how might this survey help address some of the healthcare challenges we've discussed, particularly around the ER utilization?
Well, just before the pandemic, and I'll use this as an example. Just before the pandemic, we were working closely with departments and the regional health authorities and other health service organizations like extramural program with Medivie Health Services in trying to demonstrate the value of identifying target populations. I alluded to earlier people with many chronic conditions, for example. So the value in identifying target populations, so we have a better sense of the realities of these populations and can understand their needs better. And if we are able to meet their needs better, their interaction with the system should be far more efficient. So as an example, one of these initiatives in previous years was around reducing those visits to ER. And what they did was through looking at these prevalencies of people with chronic conditions and then working their way through the actual individuals, they could tell where there would be a benefit in having this type of initiative in place, which would be to identify these users, have a better understanding of their health realities, have a better understanding of the type of support they would require. And they've seen significant reduction in the use of services by these individuals because the service they were providing to them was more adapted to their own needs. So it also means these individuals' needs were being met better. So these types of initiatives can be supported with the type of information that we gather through these surveys. It's one part of that picture. Other things are that we've seen it sort of provoke reactions in some communities. So, for example, we talked about obesity in New Brunswick for quite some time, and no one liked to hear that New Brunswick had a higher prevalency of obesity than other provinces and so forth. That's not nice to hear. But when we were able to produce those numbers far more locally, it's interesting to see how it generated interest towards local initiatives to promote better eating, physical activity. So when communities are better informed, their efforts can be far better targeted, and it's for the betterment of the health in their communities.
Mm-hmm. In the January 2025 progress report, it discusses the My Health NB as a key initiative that gained popularity during the pandemic and is now being expanded. So how can digital solutions like this help the 21% of New Brunswickers that don't have a primary care provider?
Well, I'd say two parts to that. So there is one part where with initiatives like My Health and B, we're exploring opportunities for other ways to capture this type of information from citizens, capture it more in an administrative fashion, which could make it easier than trying to do this through surveys. And it's the same information. It would also support, then the emphasis would be on people updating this information. So that's an example. The other angle, as far as virtual and virtual tools, we did examine the use of virtual care in primary care, and there were some very key messages that were provided from citizens. I'd say first and foremost, virtual care was welcomed in situations where people did not have a primary care provider. They could access at least someone, and the issue for which they needed help was, let's say, from a medical perspective, relatively simple. Ear infection, for example. And so for these people, rather than having to wait hours and hours in ER, having that option to call and have someone help them, very, very beneficial to them. They were very happy about that. Mm-hmm. The flip side is that for a lot of people that have perhaps more complicated situations, they raised the risk associated to not seeing someone in person, and also the risk for some providers to overuse the virtual tool to the detriment of in-person meetings, for example. So those concerns were raised as well. What we did learn, though, is for those primary healthcare settings pertaining to their own patients, that a number of places have learned to use this in a very complementary way. So it's not about replacing in-person visits with virtual, but for example, you're my doctor. We have met in person. I've been diagnosed with a condition, and it may be the case of a simple follow-up, and that we're using virtual to do that, and I may have limited mobility. That saves me what I used to have is find a drive and find someone to bring me to the doctor's office. So technology, when it's being used in a way to improve services, that's been demonstrated to be very helpful as well.
Like improving the patient experience.
The problem is when technology is seen as a replacement overall. Right. So it has to, your healthcare needs that, yes, it can benefit from high tech, but it still requires high touch.
For example, doctors are using AI. It's not meant as the doctor, it's meant as a tool to complement the knowledge of the doctor. Now, various community initiatives have been launched to help with recruitment and the retention of healthcare professionals. How important are these non-clinical approaches in building a stronger healthcare system?
Well, the community can play a big role in supporting these recruitment efforts. When these professionals are coming, for the professional themselves, anything that makes them feel comfortable about choosing to work in that area, for which these local authorities can play a very important role in helping promote their area. Sometimes these professionals also have spouses that also need to work when they come in, and being armed with this information, networks within the community can help in supporting that spouse in finding a work opportunity as well. So there's that collaboration is an important one, and it can make a difference in local efforts to recruit all types of health professionals.
Is there a retention problem in New Brunswick with doctors, you find?
Well, New Brunswick is one of these jurisdictions from an immigration perspective. We sometimes have that challenge, not having bigger cities where people from certain parts of the world, they don't necessarily have a a common community of interest with other individuals, may find it a bit more difficult to integrate. So that can happen. So retention can be an issue there. And aside from that, we are seeing also in the nursing field, and that's less to do with necessarily attracting in, but we're starting to see some challenges in keeping our nurses in the public sector positions, and that's a worrisome trend as well.
Is there anything that the council is trying to do to keep them in New Brunswick? Like the
Well, the
nurses?
council doesn't manage any of these programs, but from a council's perspective, as far as what we can bring to the table is, and for a public sector when it comes to healthcare that doesn't have a tradition as being very transparent or of engaging citizens and communities in a very effective way, that's where we can come in. And by having more people understand these issues, these problems, these opportunities, at the end of the day, it's really proving that to have an effective publicly funded health system, it's really a team effort. And our funded health services by themselves cannot face the challenges and win just by themselves. So it's really important to have informed citizens, that we understand how we also have a role to play, but also for many of our community stakeholders as well. And that's where the council can contribute to that overall knowledge.
So what do you think is the most important step that New Brunswick needs to take to strengthen the primary care access for all the patients, residents?
So there'll be two parts to my answer. The first one, relatively quickly, in a sense that the ingredients themselves are well known across the country. Everybody's talking about moving towards more of a team base. Everybody's talking about a model that ensures that 100% of the population is linked to a primary health team or a primary health service. Everybody's talking about the importance of all the roles around that team. So obviously that's a big part of the answer. Now, what we're also learning here and across the country is that it's not enough to simply put the elements in place. It's not enough to have, let's say, a social worker with a doctor, with nurse practitioner, and so forth, and call it a unit. We really have to have the management behind that, and the management that ensures that whatever we have in place, that it's being managed with a proper understanding of the clientele base that we're serving, that we can appreciate those subgroups for which we have to pay particular attention, and that we're also managing in resources in such a way that we're ensuring that timely access, the proper hours of operations, and so forth. And that's one of the lessons that's being learned across the country, is that we can't underestimate the importance of how these should be managed. And here in New Brunswick, we also outlined that we have to clarify who's responsible for these. Contrary to surgical wait times, for example, that are part of hospitals, that are managed by the regional health authorities, no one really manages primary care. You have people working independently. Teams may be formed spontaneously voluntarily. But what's the management structure behind this sector that we're aiming to create? Who's ultimately accountable for the state of primary care for each of our health zones, for example? And so we recommended in previous years that regional health authorities should be ultimately responsible. We've not changed that point of view, but that responsibility element and the, let's call it a proper accountability framework element, needs to be solved as well.
So thank you, Stephane. Thank you for your time and for sharing your insights.
You're very welcome.
To our listeners in New Brunswick, please make sure to fill out the new population health survey that is making its way to you, and be a part of shaping better healthcare policies. Please like, share, and subscribe to our podcast. And thank you for listening to Prescription for Primary Care. Until next time, wishing you good health and better healthcare.